Okay, our presenters here today are Paul Cantrell, Tim McNeil, and Kathy Vesely-Massey. Paul Cantrell is Executive Director and CEO of Comprehensive Care Connections, a nonprofit administrative services organization created by and for the benefit of AAAs. Tim McNeil is an independent healthcare consultant specializing in health program development and sustainability. Kathy Vesely-Massey is President and CEO of Bay Aging, a nonprofit area agency on aging, which is a AAA, serving rural Eastern Virginia. In 2017, she accepted the John A. Hartford Foundation Business Innovation Award for forging a statewide coalition of AAAs named VAAA Cares. VAAA Cares contracts with health systems, MCOs, and other health providers and insurers. And with that, I would like to welcome Paul, Tim, and Kathy. Welcome.
Thanks, Steve. This is Paul, and I'm going to take you through the first part of our presentation this afternoon. And we're going to start, let's see, here we go, getting to knowing your audience. And just so everybody understands, I want to take you through kind of a high-level discussion of what MA plans care about and how they're different from some of the work that AAAs and other CBOs traditionally and often work on. Then I'm going to turn it over to Tim, who's going to take you through the specifics on what's changed in Medicare Advantage and what really brings folks to the call today. So where is that opportunity? And then last, as Steve talked about, Kathy, with her experiences in Virginia, is going to take you through a little bit about how they've thought about this down in Virginia. So, going to my next slide here. So looking at Medicaid LTSS versus Medicare Advantage, or for those of you who are not in some type of a managed LTSS, you may be under your aging waiver that you're working on there in your state. So many of you on the call already know about Medicare Advantage, but I want to make sure and do a level set here to make sure everybody does have the same perspective with what's going on in Medicare Advantage. So let's start by taking a look at why we should care about this population if they're not in the aging waiver or in other services that we provide, and start with how many folks are in there, what percent of the Medicare population, that kind of thing. So there's 36% of the Medicare Advantage or Medicare beneficiaries are currently in Medicare Advantage, and that percentage, if you turn it into numbers, and we'll talk about that in just a moment, is actually more than the total population of the country that receives Medicaid home and community-based services today. So the population is quite large, and it's growing rapidly. And the projections are that by 2027, it'll be 41% of the entire Medicare population. And today, in many states, it already exceeds that number. So we're looking at 50% or higher in some states. And the specifics, when we start talking about what's changed, as you'll see when Tim talks about this, some of the new opportunity is only available through Medicare Advantage plans and not through original Medicare. I'll leave Tim to talk about the specifics on that. This is a slide, as Steve said, I work with an organization called Comprehensive Care Connections, or we shorten that and call it C3, in Pennsylvania, and that's the AAAs there. And this is a slide that I use for them to give them a perspective on how large the opportunity is in Medicare Advantage. The green line on your screen is total number of Medicare Advantage participants in the state of Pennsylvania. The blue line right at the very bottom of the table there is the aging waiver participant population. So as you can see, it's a much larger opportunity as far as number of participants, and for the most part, a large part of this is right in our wheelhouse. So for CBOs on the phone, you're probably either working with older adults or you're working with those who are disabled, and that's the heart of the Medicare Advantage population as well. So at a 50,000 foot view, and let me be really clear when I talk about this, it's 50,000 feet. These are general statements about Medicaid, and you'll see in a minute I'll talk the general statements about Medicare. Because this is a state program, it does differ to some degree state to state. So if all of these aren't exactly the way this works in your state, I understand that, but just as a general rule when you look across the states, that it's all ages. There's means to testing involved. And many states have behavioral health carve-outs for the program. And for those of you that work specifically in the LTSS population or long-term services and supports home population with providing home and community-based services, this population tends to be a much sicker population and with a lot of chronic conditions. MLTSS enrollment in many states is also, in some states, there's both active and passive enrollment. And as you'll see in a minute, that's different under Medicare Advantage. They also, in MLTSS states, many states have a very easy in and out process where people can change on a monthly basis, for example, from one MLTSS plan to another, or from MLTSS back into a more government-run long-term services and supports Medicaid program. And here are the numbers here. Medicaid, home and community-based services, 5.9 million. That is 2012 numbers. I did not have current numbers on that. Certainly, I would assume that population has grown some, and I don't know, Tim or Kathy may have more up-to-date population numbers, but that gives you a perspective on how many folks are in that. And the total spent on home and community-based services through Medicaid, $94 billion in 2016. And you start thinking about, so what do the health plans really care about? This gives you a good perspective on that. It's really, how can we help people be able to stay in their home? And that's when they start applying community services in the Medicaid space. We're trying to help people to be able to stay in their homes and their community living situations for as long as possible. And as you see, this slide shows how much cost savings there is to the system. So either to the state in the Medicaid system or to the managed care plans if they're under a risk, if you have MLTSS and they're under a risk model for this. So a big focus of the work under LTSS is how do we keep people out of being in a residential nursing home situation. And as you'll see, some of the emphasis changes a little bit under the Medicare side. So let's look at Medicare Advantage for a moment. It's obviously, Medicare is a federal program, and so is the Medicare Advantage program. So at a 50,000-foot view, it's a single program across the country. Now, the Medicare Advantage plans certainly apply and get approved for the plans in the locality, the geography that they intend to offer that. So within your state, one MCO may offer multiple Medicare Advantage plans in your state. And you may have across all the MCOs quite a number within your state, or a few depending on where you are. But still, it's one federal program. Who's in the Medicare Advantage plan? Same people who are eligible for Medicare. So those that were over 65 and the disabled population that have qualified. And as the last slide, we talked about the emphasis with Medicaid. A lot of it is keeping people out of the nursing home. Under Medicare Advantage, there is no long-term nursing home coverage. So that piece of it, unless you're talking about a SNP plan, a dual SNP plan that's integrated with their Medicaid plan, then that piece is not viewed as in the same way that it would be under a Medicaid plan. The Medicare Advantage plan is concerned more about health and less about housing, except as the housing impacts health itself, and Tim may want to talk about that a little bit. So from an enrollment standpoint, there's an annual enrollment period, there are special enrollment periods, and then there's the new enrollment period that you can make the change right after the first of the year that we're seeing now. But the point here is that people are more likely to be in a plan for a full calendar year under Medicare Advantage than under a Medicaid MLTSS type of a plan. Then when you look at what they're really focused on, you'll see a lot more focused on health and wellness. Because you have active enrollment with all different levels of health with this population. You have some very healthy individuals, active seniors that are in there. And the Medicare Advantage plans care about them as well. So when you're talking to a Medicare Advantage plan, you have to look broadly at all those different types of services that you could offer them. And then the active enrollment. So if people end up in a Medicare Advantage plan, it's because they selected it, or if they needed help either through one of your programs that provides them options, or through a loved one who helped them choose, they actively enrolled in the Medicare Advantage plans, as opposed to in some Medicaid systems where there's a passive enrollment or auto-assigns. And then there's the piece that we're going to talk about today with home and community-based services. Historically, it has been limited, the ability for the Medicare Advantage plans to provide the types of services that community-based organizations typically offer to this population. And Tim in a minute is going to talk a little bit more about what's changed in the rules and why that's really important and as an opportunity for community-based organizations. We talked already a little bit about no housing coverage under the Medicare Advantage plans for long-term care, and traditionally no home and community-based services. But Tim will tell us how that's going to change. And then you see there the MA enrollment numbers there on the screen as projected. So what's going to be important to the MCO? So again, at a 50,000-foot view, looking at quality metrics. They either through HEDIS, STARS measures, they have a lot of different measurements that they have to look at because the federal CMS has required them to look at it, but also for them, they're thinking about this, how does this improve our bottom line and how does this improve the person's health? And did the effort identify previously unidentified health conditions? There's a piece in the way that they get paid through CMS that has to do with the diagnoses of their participants. So if you help them identify undiagnosed conditions, that can help them from a revenue standpoint. It also helps them, obviously, to serve them better if they know that somebody has, let's say, some chronic condition that the plan didn't know about previously. So identifying those is important to them as well. And then helping them to measure the health or behavior change. They're constantly looking at how do we move the needle. So your ability to help with that is really important as well. And then the last and one of the most important things, obviously, to an MCO is, did you help drive savings or an ROI for them and their bottom line? Because they have the risk of the cost of care. I would also point out, if you're not aware of this, the Long-Term Quality Alliance put out a paper this past fall that I think is very instructive about how the MCOs are thinking about this. So I'd encourage you to go out and look and pull down that paper, because it does a nice job of going through, because they did a survey of the MCOs and what they're thinking about with these new supplemental benefits. So I'd encourage you to go out and take a look at that paper as well. And then just to sum up, what do the MCOs care about at a high level? They care about a lot of the same things we do in the AAA. We obviously want the people we serve from a CBO perspective to have a good experience. So what is that customer experience like, and improving that, improving population health. We all want to make a difference in the people's lives we serve, and the MCOs care about that as well. And then they care about lowering costs, and there's your AAA. Part of all that is closing the HEDIS gaps, improving their STAR ratings under Medicare Advantage, client satisfaction, and return on investment. And with that, I'm going to turn it over to Tim to talk about specifically what's changed at the Medicare Advantage level and how that creates opportunities for you. So Tim, turn it over to you now.
Thank you. So I'm going to talk about the Chronic Care Act and the changes to the Supplemental Benefit Program under Medicare Advantage. So there were some rule changes. I began tracking this in 2017 when the first proposed rule change came out in two parts, where CMS announced that Medicare Advantage plans would have increased flexibility to tailor services for the needs of beneficiaries. The final policy was released on April 2nd of 2018, and then April 27th is an important day because that's when CMS provided guidance to Medicare Advantage plans to assist them with preparing their bids in case they wanted to incorporate supplemental benefits into the service delivery. So in 2019, beginning January of this year, health plans that were authorized to include supplemental benefits were able to provide those services. And well, under the expanded definition of what supplemental benefits were. And this is important because in the past, supplemental benefits were really only tied to things that expanded on the delivery of medical services, and beginning in 2019 is pivotal because that was the first time that supplemental benefit packages could include non-skilled services, particularly if those non-skilled services could reduce readmissions or improve health outcomes. So there was a reinterpretation of the supplemental benefit that was released by CMS, Centers for Medicare and Medicaid Services, where under this reinterpretation, CMS would allow Medicare Advantage plans to include dual eligible special needs plans to allow supplemental benefits if they're used to diagnose, prevent, or treat illness, but even more importantly, to compensate for physical impairments or to ameliorate the functional or psychological impacts of health or reduce avoidable emergency utilization or healthcare utilization. Another important aspect, and you'll see how this is implemented on the ground later on when I give you real examples of how some large Medicare Advantage plans are utilizing this supplemental benefit rule change, but there's something called uniformity flexibility. Essentially, in the past, whenever a Medicare Advantage plan provided a benefit, made that benefit available to their beneficiaries or their members that are enrolled in the plan, it had to be uniformly available to all beneficiaries that were part of the plan. This rule change allows for a change in uniformity flexibility so that it enables a plan that adopts supplemental benefits to target the supplemental benefit services to certain segments or certain targeted populations of members that are enrolled into the plan. And so that is an important aspect because you'll see later that many of the plans are targeting these supplemental benefits to specific populations. So if I am a community-based organization or I am an organization that can provide those types of services, I have to understand how that health plan is going to target the population so that my services are in line with their needs. So the effective date of the rule change, the supplemental benefit and uniformity flexibility rule took effect for the 2019 benefit year. The benefit year for Medicare Advantage plans follows the calendar year, so that began January 1st. The bid packages, every Medicare Advantage plan has to resubmit their bids for the following year, and that bid package is usually due in June. So for 2019, every plan that wanted to incorporate supplemental benefits as part of their services, they had to have that included in their bid that they submitted June 30th. CMS began offering training for Medicare Advantage plans to assist them with preparing their bid, and that began in April. The key thing is that earlier in the presentation I said that CMS provided a guidance memo to Medicare Advantage plans on how to incorporate supplemental benefits into the services that they're offering any potential Medicare Advantage enrollee. And that guidance memo was released on April 27, 2018. Well, as I said on the prior slide in here, that their bid packages were due June 30th of 2018 for services that start January 1st. So as you see, for this first year of this rule change around supplemental benefits, there wasn't much time for a Medicare Advantage plans to do much planning around how those supplemental benefits would be part of their bid, because they got the guidance at the end of April. They have to submit their package in June, and the package has to be certified by an actuary. So it really was not a lot of time. But even though there was a shortened window of time for them to prepare their bids and incorporate supplemental benefits, you'll see later on that many health plans, Medicare Advantage plans, actually were able to get supplemental benefits included into their benefits and have begun offering those benefits to their beneficiaries for this year. At the same time, as CMS was adopting this reinterpretation of supplemental benefits and adopting the rule change, there was something that was included in the Bipartisan Budget Act of 2018. And so in the Bipartisan Budget Act of 2018 that's now has taken effect and signed into law, it included something called the Chronic Care Act. And the Chronic Care Act now makes it permanent that there is an opportunity for Medicare Advantage plans to have targeted supplemental benefits that are non-medical, non-skilled in nature to address any person that's enrolled in a Medicare Advantage plan that has multiple chronic conditions. An excerpt from the legislation and the Chronic Care Act essentially outlines that the Medicare Advantage plans will have increased flexibility to target these supplemental benefits to any enrollee that has chronic conditions. Again, the Chronic Care Act also included language to allow a Medicare Advantage plan to waive the uniformity requirements and target those services to specific types of beneficiaries. So I talked about the guidance memo that was released by CMS on April 27th. So that guidance memo had specific categories, and those categories were outlined by CMS as options for a Medicare Advantage plan to consider when adopting supplemental benefits as part of their bid package. The listing of items was not meant to be exhaustive in nature, so a plan can recommend or propose things that were not in the list, but the listing of items gives some guidance to health plans around how CMS will be looking at supplemental benefits. So as you see, many community-based organizations provide these services, one or more of these services in their community, and now those services can be paid for as a supplemental benefit if a Medicare Advantage plan has chosen to incorporate the service as part of their benefit. So those key categories can include things such as adult day health services, in-home support services such as personal care aid services, support for caregivers and enrollees. So some plans have proposed things such as respite services as a supplemental benefit that benefits the caregiver and the enrollee, standalone memory and fitness benefits, home and safety devices and modifications, so things like grab bars in the shower, those things, transportation as well. Now, a health plan that has chosen to incorporate supplemental benefits as part of the services that they will offer, in addition to being able to target those services or benefits to a particular population, they also maintain the right to have a process in place to make these services authorized for a person. If you are working with a Medicare Advantage plan in your market, particularly one of the ones that I'll show later that have decided to adopt supplemental benefits, and there's an opportunity to talk about how your services can assist the health plan, you also are going to need to understand if that particular plan has a prior authorization process in place that you have to go through in order to receive authorization to deliver the stated required supplemental benefits that the plan is making available to a beneficiary in their plan. So the market response to the rule change, so CMS, the Centers for Medicare and Medicaid Services, released a press release on September 28, 2018, where they identified that 270 Medicare Advantage plans were approved to provide supplemental benefits under this rule change, and that those 270 Medicare Advantage plans will potentially impact 1.5 million Medicare Advantage beneficiaries that now will have access to those services. And according to the CMS benefit, the range of services that were proposed by the 270 plans that were approved include adult daycare services, in-home support services, caregiver support services, home-based palliative care, and non-urgent transportation. So you see that at least the initial set of Medicare Advantage plans that received approval from CMS to offer supplemental benefits, they chose the items or services off the list of recommended items that were included in the guidance memo that CMS released. And again, I want to just highlight that there was a very abbreviated time window between when the plans received the guidance on April 27th and when they had an opportunity to submit their final bid. And even though they only had from April 27 to June 30 to complete that entire process, 270 Medicare Advantage plans completed the process and received authorization and approval to begin delivering these supplemental benefits, and those services became available to any enrollees in their plan starting January 1 of 2019. So I also was able to look at research that was provided by the Better Medicare Alliance, and they commissioned a report where they identified that for 2019, their data showed 102 plans reported offering specific supplemental benefits, and that included home-based palliative care, which was going to be offered by 29 plans in 5 states, and a range of in-home support services that were going to be offered by 51 plans in 15 states, and also medically approved non-opioid pain management services. Based on the information provided by CMS that 270 Medicare Advantage plans were approved to deliver services, I began looking at some of the large Medicare Advantage plans across the country to see what they were reporting and marketing to potential Medicare Advantage enrollees about what supplemental benefits that they were offering. So this information is available on those health plan websites and can be accessed through their websites. So first, I looked at UnitedHealthcare. So UnitedHealthcare promotes on their website that as part of their supplemental benefits, they are going to offer transportation. Those non-urgent transportation will impact about 1.7 million beneficiaries that are enrolled in their plan, and as well as caregiver resources to support caregivers in the management of care. So if I'm working with UnitedHealthcare in a particular market and I know that they have a large penetration of Medicare Advantage enrollees in my market, then I should know that they are offering right now transportation and solutions for caregivers. So if my organization has, for example, I offer home-delivered meals, I should have knowledge that UnitedHealthcare, at least for this first year, is not incorporating home-delivered meals as part of their offering, at least what they're promoting on their website. Now, a local plan may make some changes in their decisions, but at least this is what they're advertising. I looked at Humana. Humana is promoting on their website that some of their supplemental benefits include dental benefits, hearing and vision, fitness program membership, and home-delivered meals following an inpatient stay. So I think a key thing there is you see how Humana has decided, based on what they're advertising and promoting on the website, that they're going to target a home-delivered meal supplemental benefit to a target population of enrollees that have had an inpatient hospital stay. So if I am working with a health system in my market, and let's say that health system has a strong relationship with Humana, and maybe there's a lot of Humana beneficiaries in my market, if I talk to Humana about just a general home-delivered meal service, they may or may not be interested. But if I'm able to present that my organization is working closely with the largest hospital in my market, and that particular hospital is managing Medicare Advantage and Humana enrollees, and we want to have a targeted approach for home-delivered meals that's tied to an inpatient stay, now I've crafted my presentation to the Humana Health Plan in accordance to what they're promoting as how they're going to deliver supplemental benefits in the market. So I may have increased interest from that health plan to incorporate my organization as a provider of supplemental benefits, specifically targeting a home-delivered meal benefit post-discharge from my partnering hospital in my community. In contrast, Cigna is also promoting on their website for their Medicare Advantage product that they are offering transportation to medical appointments and home-delivered meals for 1 week following an acute inpatient hospital stay. So you see, again, Cigna are promoting on their website that they're using the uniform flexibility provision in the rule to target a home-delivered meal supplemental benefit to beneficiaries that have had an acute inpatient hospital stay for 1 week. So what I promote, if I had that market research data about Cigna, and I have an opportunity to work with Cigna, let's say in the Texas market where we know that Cigna has good penetration in that market. If I'm promoting my benefit, I would talk about how I could target a one-week home-delivered meal benefit service for persons that are working with the, that my agency is working with in partnership with the local hospital, so I'd know that I'd be able to deliver those services post-discharge. Now let's say that I have a waiting list for meals, or it takes me 2 weeks to add a new member onto my route to deliver meals. Well, that's not going to help me in becoming a vendor for Cigna under the supplemental benefit rule, because they're looking for vendors that can deliver home-delivered meals 1 week tied to an acute inpatient stay, so it has to be closely timed to the discharge. So I have to have a rapid response mechanism to trigger the delivery of home-delivered meals to meet that beneficiary post-discharge in order to be successful in my presentation, negotiations, and discussions with the Cigna based on how they're presenting that they're going to utilize a supplemental benefit to enhance their services for their members. Lastly, Aetna. So on Aetna's website for Medicare Advantage, they promote that they are offering in some target markets that they're offering home-delivered meals after a hospital discharge. And I think you're beginning to see the theme here, where they are looking at a targeted supplemental benefit. And it also, as Paul stated earlier, that some health plans are tailoring the use of supplemental benefits, and that aligns with getting improvement with HEDIS measures. So there is a HEDIS measure around readmissions. So if they can target a supplemental benefit such as home-delivered meals to meet the needs of a beneficiary after discharge, hopefully that will provide additional support for that enrollee in that plan to bring down the likelihood or potential of a readmission, and so they can get improvement in that HEDIS measure around readmissions by targeting a supplemental benefit to a beneficiary or an enrollee, and target that service using a uniform flexibility to tying it to the discharge. And if I want to service those persons, I have to have a mechanism to deliver that service tied to the discharge as well. Now I'll turn it over to Kathy to give an example from VAAA Care.
Okay, thank you, Tim. In VAAA Cares, I would like to start by just walking through very quickly how our collaboration works. We are a collaboration of area agencies on aging from across Virginia. We cover the entire Commonwealth. The area agencies on aging, of course, are networked with a lot of other service provider organizations in order to really have a depth of services here. We have 25 AAAs in Virginia. However, not all 25 are active in this collaboration. Those who have the capacity have joined us. And it is, I think, real important to note when you're trying to do a regional or statewide approach that it is critical that everybody in the network understands that you cover the state, you cover the region, and you do not go by pre-existing territories or regional lines that have existed in the past. The legal entity is Bay Aging, and we established the collaboration through contracts with the other AAAs. We are working with two health systems, two major health systems and another hospital, and we have 3 major MCO contracts at this time, and of course, as always, are negotiating more. When we look at our strategy for approaching these supplemental services, I would say that our CARES transition is our strongest product. We start with the CARE transition, and then we look at a lot of other add-ons to it that I'll move through very quickly here. But all the participating agencies must be able to deliver these services. So like the pieces of a puzzle, if there is an area not covered by an agency on aging, we will hire and make sure the coverage is there in order to be able to track a Medicare Advantage contract, a statewide contract with some of those large providers, such as Tim was just referencing. Our value proposition is very varied. We are, at first introduction, we let the potential payer know about our components, a big emphasis on being able to do individual patient assessments. Then the usual in-home transitioning of medications, PCP appointment adherence, red flags, patient-centered records. However, we also incorporate a lot of prevention so that the payer can determine what their priority needs are, be it for chronic disease self-management, diabetes self-management, fall prevention. We offer healthy ideas doing the PHQ-9, which, as you have heard, that can be very important to upping the ratings for some of these payers, advanced care planning, and telehealth. Of course, all of those home and community-based services are at our disposal that Tim has already mentioned, so I won't run through those again. For our proposal, a presentation sample, I think that what we have is what we call our two-pager. It's an overview that looks at the potential services that a Medicare Advantage may want. Now, we have two different proposals. One is what we use when we're working with a Medicare Advantage health plan and how we can help them in their savings, what the return on investment is. Another is targeted more to the health systems and to physician payers. There we are, again, emphasizing in-home assessments, person-centered planning, just that management and delivery of wide array of home and community-based services, and a big emphasis on the just-in-time home and community-based services, be it for community transitions, SNF diversions, or other community-dwelling moderate risk individuals. And as part of our overall legal entity, we do offer centralized invoicing and payments and reporting. Now, to move from the proposals into the some particular examples in our last few minutes, I'd like to talk to you about, first of all, one hospital. It's a health system, very large health system, where we went in to do a pilot with the hospital paying from their budget at first to have us do care transitions to reduce the cost of high utilizers. The program was a great success, but we quickly needed a way to sustain it. Medicare Advantage planning became the sustainability plan, and so it was, I wouldn't say easy, but it was a matter of, as Tim talked so eloquently, leveraging that health system relationship with the Medicare Advantage plans to have them come together, seeing the value that we could bring in doing our assessments and bringing those services into the home, the services as they requested. Okay, and the next one is the Independent Physicians Group. We also just recently have been pursuing a very large accountable care organization physicians group that is a major primary care provider for Medicare Advantage plans. These are groups we've talked to in the past that are much more interested now that we can provide the codes and that there is flexibility to have Medicare be reimbursing us as opposed to it simply being an added cost to the plan. Likewise, I think when you think of the MLTSS population, one of the, I guess, barriers to utilizing some of the community-based organizations was how it had to be billed up from the medical loss ratio. And so without becoming too detailed, just to let you know, we have the ability now to have them actually billing out of the funding that's available for such programs and supports. So the research on available billing codes has been very important, as has been utilizing our Medicare NPI so that we can bill directly when it comes to diabetes self-management or medical nutrition therapy items that are frequently being explored by the physicians and the other healthcare providers. So the overall testing has been very interesting for us. Just tried to bring it all together. We have a large health system that has its own hospital-owned physician group that wants to purchase our care transitions. They want to immediately be identifying their patients that have Medicare Advantage plans that could benefit from these supplemental benefits. So we are going directly now to the Medicare Advantage plans to work with the specific patient members and their physician groups to see how can we work and target these individuals without it being a burden on either the health system budget or the physician group budget. As you may well know, many of these various codes that we are using in the billing processes, it does require the physician to authorize. So working in tandem with these providers, it's a not a one-stop shop such as you walk in and say, here is the deal, take it or leave it, but to really work with them to understand what codes they're using and how you can supplement their existing service structure. Once in preparation for this particular webinar, I was talking with Tim and said, well, Tim, what do I add to the mix that you can't already talk about? And he said, tell your story, Kathy. You are persistent, and it does take that persistence with these plans and with the various healthcare providers to really make a difference and to help them understand how you can work together. So it is, sometimes it feels like an uphill battle, but it is well worth the future of healthcare in the United States.
Kathy, I don't know how you did that, but you wound us up right at 1:45. Great job.
That was my
job. So, Steve, are you on?
Yes, I am.
Okay.
Thank you, everyone. Thanks, Paul, Tim, Kathy. Lots of great information here today. Everyone, it is time for the Q&A portion of today's webinar. So if you have any questions for our presenters, now is the time to send them in. And presenters, let's jump right into it here. The first question here, can you discuss the MA authorization for home health care services? I work in a home health care organization, and all of our patients with MA are only approved for 5 visits total.
So the authorization for home health benefits is separate and distinct from a supplemental benefit. And so health plans have the opportunity to provide flexibility in how they define offering services. Many of them do have a prior authorization process where a enrollee is eligible for services like a home health benefit. The plan then says they're only eligible for this many visits. Usually there's also a process of appealing that decision or expanding the benefits to add in different services. But I just want to make sure I reiterate that that would not be part of a supplemental benefit. It would be part of a medical benefit for home health services.
And Tim,
right,
that they could be different. So as you were just describing, the MA plan submits their services that they're going to cover. So one plan that you may be dealing with covers the 5 visits. Another one might cover 3 or 7.
And then one more thing, that because a person has an authorization for home health services, that does not mean that the beneficiary could not get supplemental benefits, because the supplemental benefit, as was identified, it could be for home delivered meals, and they could be getting home health services at the same time, and both coordinated around the discharge from a hospital.
All right, thank you. Next question, can you expand and talk a little bit more on how the plans are allowed to target the benefits?
So when they submit their bid package, they are also supposed to submit how they plan to target the benefits to specific populations. And so they have a lot of flexibility. They could target their benefits to disease groups, target it to geographic locations, social determinants. All of those things can come into how they decide to target the service. As was identified in some of the examples, many are targeting the benefits around a hospital discharge. So now on the plan side, we talk about authorizations. They would establish some eligibility criteria for supplemental benefits. That eligibility criteria would be made available to all the care managers and the portion of the plan that is providing the authorization for the supplemental benefit services. An enrollee that meets that eligibility criteria then would have access to the supplemental benefits, and then a vendor that's contracted with the health plan could receive authorizations to be delivering that service. So the example, potential example in Virginia, BAAA Cares working with a large health system, and they potentially are working with a Medicare Advantage plan that wants to target benefits around hospital discharge. So the eligibility criteria would be that person has to be admitted to have an acute care hospitalization, be a member in the plan, and could benefit from the supplemental benefit service. They would submit that information to the plan, obtain authorization, and then they'd be allowed to deliver the service, and the plan would pay for that service delivery as a supplemental benefit that's offered for the beneficiary that met the eligibility criteria.
Tim, I would add to that too. This is a point that you want to emphasize, I think, when you're going in, and make sure that you've thought about this piece and how it would be tailored, because a lot of the things a Medicare Advantage plan offers, they must offer exactly the same to everybody. This supplemental piece, they provided this flexibility. So it's an opportunity for you to help them think about how you could really tailor it in, and that helps with that return on investment for the plan.
And that's a great point. And you caused me to remember something that I really wanted to say, is that I emphasized a lot around the shortened time period that a Medicare Advantage plan had to prepare their bids for the January 1 start, but they know now that they have from now until June to prepare their package for 2020. So for January 1, 2020, we now have between now and June for those health plans to begin discussing what are the supplemental benefits we're going to provide and what are the target populations we're going to include or provide those services for. So if I'm in a market and I'm working with a Medicare Advantage plan, or like Kathy, I'm working with a large health system or a large physician group in my market, I want to engage in a discussion with my local Medicare Advantage plan now and help them to shape the Medicare Advantage supplemental benefit going into the next benefit year, and I should enter into a dialogue with them around these are the types of services that we collectively, my agency and my partnering health system and providers, want to deliver to a specific subset of the population, and we want you, the health plan, to incorporate that into your bid package to be made available January 1, 2020.
All right, thank you. The next question here, can you talk a little bit about costs? Will these new plans cost more? Because that's really always what it boils down to.
So it's not a new plan, it's a new benefit added to a plan. And these plans have to be competitive in their particular market. So during open enrollment, Medicare beneficiaries will have an opportunity to sign up for a large array of Medicare Advantage plans in their particular market. If a plan is not cost competitive, then people won't sign up for the plan. So the health plans are looking at how they can strategically incorporate these benefits into their benefit package and make them palatable to the potential market of beneficiaries that they want to sign up for the plan.
I think it's probably more likely that they're going to be looking at this as how does it help them to be more competitive price-wise, as opposed to seeing the price go up. So they're looking at things like, as you were talking earlier about care transitions or things that help with that, to lower the readmission rates. Well, that helps their bottom line. It doesn't increase costs. It should theoretically lower costs.
And that's a part of our presentation to these the various payers, is showing them how the care transitions, what the cost would be there versus what the cost of readmission is or ED visits, so that there is a competitive advantage to working with the community-based organization. And most of our most favorable reviews with that have come from ACOs, who are the MCOs, ACOs, companies that are working in that capitated arena already. So you take a hospital that's in an ACO and a physician's group, it's a marriage made in heaven.
Right, thank you. Can you talk a little bit more and expand on home-based palliative care versus hospice?
Sure. So home-based palliative care is often seen for persons that don't meet the traditional hospice criteria but still need expanded supports. So palliative care is becoming increasingly interesting in the marketplace, where beneficiaries and health plans are now offering palliative care as an interim solution for the population that kind of sits in between, but they're not yet ready for hospice.
Okay, thank you. Next question. Can CBOs bill directly the MA plans for supplemental services?
So these supplemental services are going to be paid by the health plan. The CBO can bill the health plan for the delivery of those services, but the CBO needs to be a vendor that's recognized by the plan, needs to have a negotiated an agreement to deliver those services. The CBO needs to understand what the rates that the health plan is going to pay, as well as the CBO needs to understand what is the process that they have to go through in order to be paid for those services. I had a discussion with one plan, and they said that they wanted to expand the services that they're offering for supplemental benefits to community-based organizations, but their accounting systems required the CBO to file a claim so that they can account for the expenditure. And in this particular market, the CBO did not have the technology systems in place to file the claim. And so therefore, that particular Medicare Advantage plan went with a big for-profit entity that did have the system. So we are going to have to learn how plans, what they're putting in place, requiring to pay community-based organizations. But absolutely, they can become a viable provider of these services and be paid from the plan.
Okay, thank you. This next question is for you, Kathy. On the proposal and presentation sample slide, wondering if intervention management is the same as case management.
Well, we have a number of codes there that we are working with on the various providers. So when we're saying intervention management, I'm thinking more in terms of a care transitions. We do a couple of different kinds of interventions with the various plans. But when we're looking at the codes, we're also looking at a variety of care management codes. So it could be chronic care management, collaborative care management, or the transitional care management. So there are a variety of ways to look at that, and I know that finding a way to share in reimbursements is one of the big struggles, and it's something I know we struggle with, and Tim has been a great resource in advising us how to approach that. So he may want to add.
So Kathy's just absolutely right in kind of presenting your services and speaking to the needs of the health plan. Sometimes case management is part, but you have to be careful because many health plans have case managers. So really helping them to understand how your services are different from the services they're going to provide and the value add that your services bring to the equation helps them to incorporate that service delivery. Oftentimes, phone-based case management doesn't meet the needs of a beneficiary that's suffering from social determinants. So your ability to have in-home intervention management to supplement their phone-based case management, they may understand that. But if you just present, we're going to offer case management, they may say, we don't need to buy that because we already have case managers. So some of this is how we're marketing and promoting our services in a way that the health plan understands it and they can see the return on investment.
Okay, can you talk a little bit more about how do you balance trying to sell services and products when current staff are reluctant to do more or change the culture to an earned income culture?
Well, are you asking? Well, I guess the culture change is something that we've worked on for years, and I'm not sure how to respond except to say that we have had to demonstrate the funding, and N4A Business Institute has some wonderful slides which indicate growth rate of funding for the grants-based programs has been flat at best, and with the runaway increases in cost for Medicare, it is imperative that we look at ways to tap those resources. Part of our job as a community-based organization is for advocacy, and advocacy is more than saying what's important to the various patients and clients that we're working with. It is identifying the new funding streams to be able to produce the revenues to reinvest in our programs and services. And so it's really not negotiable in our discussions at Bay Aging and BAAA Cares.
Okay,
I'd like to add that.
Oh, yes.
I just want to add real quick that so we're increasingly across the country, we are really seeing more and more that for-profit entities are recognizing with all of these changes that the delivery of home and community-based services is a potential profitable arena. And as a result, some of these for-profits are taking over this service delivery in areas where there were only nonprofits before. And so we're going to have to kind of adopt a innovation and culture change model going forward, or there really is a threat for our services from outside entities that want to come in and take over.
Okay. Well, unfortunately, we've reached the end of our hour here, and we're just about out of time, so it's time for us to wrap up. But Paul, Tim, and Kathy, I want to thank you for joining us for today's presentation. Thanks so much for being here.
Thanks, Steve. It's been fun.
Thank you.
Hopefully it's been helpful.